Now coming to the nerve supply of pinna. Nerve supply of pinna you can easily learn by a quote, Arnold faces Goa. Arnold is facing Goa. Arnold stands for Arnold's nerve. Arnold's nerve is nothing but auricular branch of vagus. Okay. Arnold faces Goa. So Arnold's nerve is auricular branch of vagus or Alderman's nerve. Now how did this Arnold nerve become Alderman's nerve? There is a tribe known as Alderman's tribe. They used to do the wriggling of the extraorbital canal with their fingers so as to stimulate the auricular branch of vagus, which is also supplying the external auditory canal. I will be coming to it soon, and because of that they will be able to stimulate the auricular branch of vagus, and this vagus, which is actually the other name for wanderer, this vagus reaches even up to the stomach. It can in fact go into the large intestine as well, and this vagus is getting stimulated, and because of that the gastric secretions increases, and because of that there will be increased appetite. Okay, now that's why it got the name Alderman's nerve. And yes, F stands for facial nerves sensory branch, also known as nerve of Risberg. Okay, nerve of Risberg. And then you have the greater auricular nerve here, which supplies the greater part of the pinna. Then you have the lesser occipital nerve, and of course you can't forget the auriculotemporal nerve. Okay, auriculotemporal nerve. Now what are the areas they are supplying? If you see this picture carefully, you will be able to see that the auriculotemporal nerve is supplying the crus of helix and the adjacent helix. Okay, crus of helix and the adjacent helix area is being supplied by the auriculotemporal nerve, and the auricular branch of vagus is actually supplying the antihelix and the conga. As you can see here, conga and the antihelix is being supplied by the auricular branch of vagus, or also known as Arnold's nerve. Okay, the tragus, crus of helix and the adjacent helix is being supplied by the auriculotemporal nerve. The greater auricular nerve is actually supplying the greater part of the pinna in the form of medial surface and posterior portion of the lateral surface of pinna. And the lesser occipital nerve, it is a part of cervical plexus, the C2. It supplies the superior portion of the medial surface. Facial is having only a small supply, that is in the root of conga. Okay, so auriculotemporal nerve supplies the tragus, crus of helix and the helix, this area, and greater auricular nerve supplies the lateral surface. Okay, the pink area is being supplied by the greater auricular nerve. It is the main supplier of pinna, that's why it's called greater auricular nerve. And yes, the superior portion of the medial surface is being supplied by the lesser occipital nerve, and the cranial nerve 7, it supplies the root of conga over here. Okay, root of conga. So it is actually combining with the auricular branch of vagus for supplying the pinna. Okay, now that you have learned about the greater auricular nerve and lesser occipital nerve, what are these nerves? These are actually part of the cervical plexus. Okay, cervical plexus. Greater auricular nerve comes from cervical plexus C2 and C3, whereas the lesser occipital nerve is only a part of C3 from cervical plexus. You also know that the face is being supplied by the trigeminal nerve, isn't it? But there is one area in the face which is not being supplied by the trigeminal nerve. What is that? It is the angle of mandible. Okay, angle of mandible. If you look at this picture carefully, you can see that the angle of mandible area is also being supplied by the greater auricular nerve. The same greater auricular nerve which supplies the pinna. Okay, the major part of pinna also supplied by the greater auricular nerve. It also supplies the small area in the angle of mandible. Okay, rest area is being supplied by the trigeminal nerve in the form of ophthalmic nerve, maxillary nerve, and the mandibular nerve. Okay, there's a clear demarcation between all these areas. So the greater auricular nerve supplies not just the pinna but also the angle of mandible. Because why I am stressing here is that this question has been asked multiple times in different formats. Okay, the question will be rearranged into a different clinical scenario like this. That is, during craniotomy, trigeminal nerve is damaged within Meckel's cave, which deficit is least likely to be present. Anesthesia over ipsilateral anterior aspect of scalp, loss of corneal reflex, weakness of ipsilateral masseter muscle, anesthesia of anterior aspect of lip, and anesthesia over the entire ipsilateral side of the face. Here, only the ipsilateral side of face is having at least nerve supply from some other area. Okay, whereas all these are being supplied by the trigeminal nerve V1, V2 and V3. But here in the angle of mandible is being supplied by the greater auricular nerve. Okay, angle of mandible by the greater auricular nerve, which is a part of cervical plexus C2 and C3, and this greater auricular nerve, it is in fact a part of the cervical plexus. It goes on to supply the major portion of the pinna and also supplies the angle of mandible. Now, I told you about the other name of this facial nerve's sensory branch. What is that? It is also known as nerve of Risberg. Okay, nerve of Risberg. Now, what is this Risberg's cartilage? Risberg's cartilage is none other than the cuneiform cartilage that you see here. It is also known as Risberg's cartilage. Okay, Risberg's cartilage. I will be asking you when I take the anatomy of larynx, then you will all have to answer what is this Risberg's cartilage and Santorini's cartilage. Okay. Now coming to the nerve supply of external canal. The anterior and superior wall is being supplied by the auriculotemporal nerve, and the posterior and the inferior wall is being supplied by the Arnold's nerve. The same Arnold's nerve or Alterman's nerve that we talked about. That's why by wriggling the finger, the Alterman's tribe are able to simulate the gastric acid secretion. Okay, because the external canal is also being supplied by the Arnold's nerve. But a small area on the posterior superior wall is being supplied by the nerve of Risberg. Okay. Now, all these things have got a significance. Okay. Whenever you do syringing on a patient, you might have noticed that the patient will start coughing soon after doing a syringing. Why does this happen? This happens because the auricular branch of vagus or the Arnold's nerve is getting stimulated. I already told you, because of stimulation of the auricular branch of vagus, you are able to increase the secretions. Similarly, the vagus nerve is also having supply to the thorax and also the lungs. And when you are stimulating the Arnold's nerve, the lungs get stimulated so as to produce the cough reflex, and that results in the patient coughing. Now, I told you about the posterior superior area of the external aortic canal is having a narrow nerve supply coming from the nerve of Risberg. Okay, nerve of Risberg, and because of that, the significance is this: the Hirt-Zellweger sign. Now, the Hirt-Zellweger sign occurs in acoustic neuroma or vestibular schwannoma. Now, why does this occur? This Hitzelberger sign occurs because of the early involvement of the seventh cranial nerve. Before the fifth cranial nerve is involved, actually it is the seventh cranial nerve that is getting involved in a vestibular schwannoma, because they both are seen within the same internal auditory canal. And yes, because of that, the posterior superior area of the external auditory canal get anesthetized, but it is very difficult to elicit this sign, and hence it is not the first sign that you notice in vestibular schwannoma. It is actually the Thiel's sign that you notice, that is the absence of corneal reflex. But for now, just remember that Hitzelberger sign is seen in acoustic neuroma, and it is in fact due to the nerve supply of the external auditory canal being by the facial nerve sensory part or nervous intermediate part known as nerve of Risberg. Now, what is the significance of the rich nerve supply of the pinna and the external auditory canal? If you are having a pain somewhere in the supplied area of the trigeminal nerve, for example, the auricular temporal nerve is actually a branch of the mandibular nerve, and yes, there are other areas which is getting stimulated by the trigeminal nerve. If the other area is causing pain, for example a toothache causing pain via the inferior alveolar nerve, and the patient will also have an earache because of the stimulation of the auricular temporal nerve. Similarly, a lot of areas the stimulation can occur. Okay, for example, I already told you about teeth, and from the video you are able to see that carrier spine is causing an earache. Why? Because C2 C3 is the nerve supply of greater auricular nerve, and this C2 C3 is getting stimulated by the carrier spine. Okay, so these are the various causes of referred otalgia which I am talking about now. The pain can come via the parotid, temporomandibular joint and the teeth, and via the tongue also, that is the anterior two-third is being supplied by the lingual nerve, isn't it? So that also can come to the ear, and from the posterior one-third it comes through the glossopharyngeal nerve, larynx and hypopharynx through the 10th cranial nerve. Okay, so cervical spine problems, esophagus problems, and nose and paranasal sinus problems. For example, even sinusitis can result in referred otalgia. Okay, so these are the various problems associated with having a rich nerve supply. That is, if you are having a pain in the ear, it is not just enough that you look at the ear. Okay, you have to properly examine the oral cavity, nose and paranasal sinus, parotid's opening you have to look for, the throat, you have to do a proper indirect laryngoscopic examination. This is very significant. For example, while I was doing my post-graduation in Trivandrum Medical College, there was once a patient who came with just earache. Okay, and I was doing the examination of ear, oral cavity. I was looking for the dental caries, but I was unable to find anything. And then I went for the examination of the throat by doing an indirect laryngoscopy. In the first year, we will be more and more enthusiastic to do an indirect laryngoscopy exam, because we have to learn that skill, and we will be doing it in a lot of patients. And this patient, it was definitely indicated because we should not miss a CA supraglottis. And yes, this patient had a carcinoma supraglottis, and the earliest symptom of carcinoma supraglottis is an earache. Okay, earache can occur in a carcinoma supraglottis and also in a carcinoma hypopharynx. Okay, and all these are due to the nerve supply via the vagus nerve. Okay, so these are the things that you have to learn about in the nerve supply of pinna and external auditory canal. Now coming to the blood supply. Blood supply of the pinna and the external aortic canal actually comes from the adjacent area, that is the superficial temporal artery, posterior auricular artery, and branches of maxillary artery such as deep auricular artery, anterior tympanic artery, etc. All these are supplying the area of the pinna and external aortic canal. Usually such questions are not asked for the exam, but yes, you can't just leave this area. That's why I just brought it up. Okay, and yes, you know that the superficial temporal vein, it is having drainage from the ear. Okay, superficial temporal vein as well as the posterior auricular vein, and the maxillary vein joins with the superficial temporal vein and then forms the retromandibular vein. Okay, retromandibular vein, which has got an anterior division as well as a posterior division, and the posterior division goes on to join with the posterior auricular vein to form the external jugular vein, whereas the anterior division goes on to join with the facial vein to form the deep facial vein. Okay, and all this goes into the internal jugular vein. So that's about the venous drainage. And so from the venous drainage of the face, from this diagram itself you can see that superficial temporal vein, posterior auricular vein, and the retromandibular vein are all very important in the venous drainage of the pinna. And where does the earlobule lymphatics drain? Is it into the deep cervical nodes, superficial cervical nodes, retroauricular nodes, occipital nodes, or internal jugular nodes? This is a question which has been asked for the MRCS. Okay, and yes, you have to know the lymphatic drainage of the ear lobule. The ear lobule has got a few parts. The pinna can be further divided into ear lobule and the part above according to the lymphatic drainage. Yes, the preauricular and the parotid lymph nodes. Okay, the preauricular lymph nodes are also known as superficial parotid lymph nodes, and the parotid lymph nodes, when mentioned alone, it is actually the deep parotid lymph nodes. Okay, so the preauricular and the parotid lymph nodes actually are draining the lateral surface of the pinna. Okay, the lateral surface of the upper half of the pinna. Okay, the cranial surface of the upper half is being drained by the mastoid and the deep cervical nodes. Okay, mastoid and the deep cervical nodes. So even the occipital and posterior auricular nodes are also draining that area. Okay, so these are the deep cervical nodes, whereas the superficial cervical nodes, this is the area which drains the ear lobule. Okay, superficial cervical nodes drain the ear lobules. Okay, so you have now learned a little bit about the anatomy of external ear, isn't it? You will be learning about the development of the external ear in the coming classes when I talk about the congenital disorder of the external ear. For now, let's revise the things which we have already learned from the anatomy of pinna and external aortic canal. So we have learned the anatomy of pinna as well as external aortic canal in detail in this lecture. We have learned how pinna has got some prominences and depressions and how they are important, that is the crus of helix, and the tragus. How the name of these things that you have to know, because only if you know the names you will be able to know the nerve supply, because each of these areas getting different nerves. For example, the tragus, crus of helix and helix is being supplied by the auriculotemporal nerve, whereas the antihelix as well as the conga is being supplied by the auricular branch of vagus or the Arnold's nerve. Okay, all these things you will be able to describe only if you know the naming of the various areas, and of course it can be asked as an image based question. Okay, so what have we learned? We have learned about the anatomy of pinna and external aortic canal in detail. we have learned about the nerve supply, the blood supply and lymphatic drainage of external ear. Okay, and we have also learned about the clinical application of the rich nerve supply of pin and extraocular canal. What is that? It is the referred otalgia that occurs. Okay, referred otalgia can occur. So you have to examine the oral cavity, throat, nose and paranasal sinus, and also look for a cervical spondylitis or a carious cervical spine. All this can result in an earache. Okay, and if you are unable to find anything in the ear, you will have to suspect a referred otalgia due to these causes. Okay, so these are the important things that you have to remember from this area. You have to remember one more thing which is very important from the exam point of view, not just the theory exam but also the practical as well as the MCQ entrance exam. You have to know about the development of the external ear. Okay, about the development of external ear you will be learning in my next class when I teach you about the various development disorders and the traumatic disorders of the external ear. It will be on congenital and traumatic disorders of the external ear. And for now, goodbye.